the medical field has improved vastly since when you started. I think the overall feeling is that people are basically unhealthier than they used to be, based on the food they eat, the lack of exercise, the work has changed. The kids, especially children. Is it true?
The example I would use is when you were growing up and when I was growing up, if you drove by a playground or the fields, you'd see kids out there playing all summer long. Okay, you'd play hit the bat, play 500. You'd see kids running around, throwing a football, kicking a soccer ball, whatever. Nowadays, you don't see kids involved unless there's an adult involved. And I think that's unfortunate because I think some of the social skills you acquire are when you have to argue with somebody whether it was a ball or a strike. Did you hit the bat or didn't you hit the bat? I mean, those are the questions, and I think that's unfortunate. I think the food has become plentiful, activity has become less. I think, I always encourage my patients to be active. I think that a lot of exercise equipment is an excellent place to hang clothes. Okay? I think if you ask me, the easiest thing to do is to go out and walk, whether it's raining, snowing, or a beautiful day. Put on your shoes, go out for a walk. If you don't go out for a walk, then you can look in the mirror and blame that guy in the mirror why you didn't go out.
Right.
So, I think that's important. I think kids playing video games is unfortunate. I think that you lack those social acquisition skills. You can deal with somebody online, but how do you deal with them face to face?
But being fit and being in a routine of physical activity really makes a huge difference.
Oh, I think it does.
Health,
no, I think it does.
Would you say it's more important than diet, almost?
I think it's more important than diet, but I think it's, I think I'm not encouraging people to go out and have ice cream and beer three times a day, but I think that in combination with exercise. It doesn't have to be violent exercise. You don't have to run marathons.
No.
Go out and walk a mile away from home. You got to walk back. And go out and enjoy the island. I go out in the middle of the island, out in the moors by Alta Rock, and I never see anybody. We have people visit the island.
Isn't it amazing?
And they don't get out of town.
Yeah.
All they got to do is figure out a way to get out there.
You want some solitude, you can find it here.
Oh, you can.
There's plenty of it.
You can.
People are so busy working, and they never even get out into there. Yeah, I took Jim Lentowski out for a ride. And, if we saw one car the entire time we were out there, we didn't see anybody out in the middle.
It's beautiful out there.
Oh, it is. Now, one issue that you're pushing these days is the opioid issue we have.
Well, actually, I've been doing it for 4 years.
You've been doing it for years.
A number of years ago, Cheryl Bartlett and I, looking at the opioid issue on the island at that time, saw that the only place people could get treatment was on the Cape, and they would go over and get methadone. Methadone is a very highly regulated treatment for opioid addiction. And that was kiboshed somewhere along the line by the people above my pay grade. So along came Suboxone. Suboxone is part of an office-based, medically assisted treatment program for people with opioid addiction. And what it does, people say to me, well, Tim, you're substituting one drug for another. Well, that's true. But to get this drug, you can get it at the drugstore. It's safe. You know what you're getting. You don't have to deal with criminal behavior, i.e. out buying heroin. And it's not costing you everything. So, then it gives you an interval when you're on Suboxone, because you don't have to go crazy, looking for drugs every day. Are we
talking about heroin addicts?
Heroin primarily.
Okay.
But it gives people a calm period where they can then get counseling and hopefully, or in some people never, but get off of Suboxone and move on with their lives. That's why we right now have Suboxone and this drug called Vivitrol. Vivitrol is a drug that will block all of the opioid receptors, and you can't get high. But you want people to deal with the things that drive their opioid addiction. And I think parts of it are fear and shame and some other issues. But that's the whole idea. We're not replacing one drug with another. It's giving people an opportunity to get clean and stay clean.
Okay. Do you hold yourself responsible as a doctor for the opioid issue?
This is a very curious fact. A number of years ago, probably 15 years ago, the Joint Commission on Accreditation of Hospitals got involved and said you have to manage pain. And it became the fifth vital sign. So if a patient had pain, you flunked. At the same time, there was a letter in the New England Journal saying that, based on very slim data, that people who were taking opiates for pain didn't get addicted. So there was this unholy mixture right there, which was driving opiate use, plus the addition of oxycodone, which is a very potent oral opiate. You know, you've probably seen it in the emergency room. You got a smiley face and a sad face. Well, if there ain't no smiley faces, the Joint Commission gigged you, and people would complain about being in pain. So a combination of some physicians, I mean, the physicians were leaned on, the Joint Commission Accreditation of Hospitals, and probably some flawed data drove this more liberal use of opiates. So yes, every physician that's prescribed an opiate has potentially a certain role in it. Opiates have their place. I mean, you just have to look at how people are using them.
What about the pharmaceutical companies? Do they have? Do we hold them responsible?
Well, everybody, you know, it's.
I mean, they want to sell their product.
I usually say that if everybody's responsible, nobody's responsible. I think they have their piece of it. I mean, they produced a very potent opiate, which is good when you need a very potent opiate. However, they perhaps oversold it, but that was partly driven by the Joint Commission on Accreditation of Hospitals. I mean, it's, you know, are anybody's hands totally clean? No, but I think it's...
Well, I'd rather have the painkiller.
Yeah.
A guy got bitten by a shark in Indonesia.
Yeah.
And he was in Bali. Just happened recently. He's an Australian guy. And his family came to see him. They would not give him any pain, the heavy duty, and he had to leave to go to Singapore to get it.
Yeah. I mean,
some countries will not prescribe it.
The pendulum,
it's amazing,
rarely stays in the middle. It swings one way or the other way.
5% of the world's population uses 80% of prescription drugs.
Sure.
That's us. That's
Sure.
amazing.
Well, except when we say use, I mean, I think there have been a large number of pill mills down in Florida, for example, where people would drive down from Tennessee and Kentucky and, you know, get a prescription for 800 oxys.
Yeah.
Well, you know, that to me is just not reasonable.
Yeah, right.
But there are people, you break your leg, you need something for pain.
Yeah.
I mean, people with malignant pain, need something for pain.
Yeah.
But I mean, we have to be careful the pendulum does not swing too far the other way.
Okay, so what are we going to do about it, Doc?
I think that right now there's a lot of pressure and a lot of publicity about the issues around opiate addiction. I think we need...
Is it a real big problem here? I mean, I know it is on the Cape.
I will tell you that I have a certain number of patients in my office that are probably 10% of what is out there. You know, we've got around 50 people. So that means
that doesn't include heroin, or does that?
No, that's heroin.
Oh, just heroin.
Yeah, I mean heroin. You know, one of the byproducts of making the oxys a lot more expensive is heroin's a lot cheaper.
Got it.
And you have the synthetic opiates of fentanyl, and there's another one coming down the line that are much more powerful. So I mean, dealing with addiction, it's a marathon. It's not a sprint.
Okay.
You know, I would say you start with providing education. I think you start addressing issues around some behaviors we can see in our kids, you know, drinking and things like that.
There's a correlation between that addictive personality
and smoking.
And smoking too.
So, so I think you start looking at those issues. I think in the meantime, you have to provide a way to help people with addiction issues. The people with addiction issues are not them, they're us. They're not some awful person. They are very responsible people that made a bad mistake, and we need to be able to help them. And that is, I think, medically assisted treatment with medications such as Suboxone, or Vivitrol, or methadone over in the Cape is one way to approach it. But it has to be in concert with counseling, because I don't want to see a young person take opiates, for 3 months and then be looking at taking Suboxone for the rest of their life. It makes no sense to me. So the counseling is a key part of it, and that's really what we're trying to raise money for. I mean, I think we have one leg of the chair. Somebody has to want to stop using. Then that's one leg. A second leg is we have the medically assisted. We can help them with Suboxone or Vivitrol. And the third part of it is counseling, because I think in some people you can very effectively dealing with the issues that drove them to addiction, and then perhaps at a certain point in time you get them off the Suboxone or Vivitrol. I think that's important. It's like AA in that I think you do the work, do the steps, sit down, get counseling. I encourage my patients to go AA, NA, to get counseling and do the medically assisted treatment. One thing I will say is, okay, if you say you substitute one drug for another, yes, but if you take people that are within the first year of using IV drugs and you get them on Suboxone, the incidence of developing Hep C is a whole lot less. Hep C is responsible for the majority of liver transplants and liver cancer these days. So, I mean, that's another part of it, is it's harm reduction initially, but it then provides an opportunity to deal with the issue.
Are you involved in starting a center? Is that going to be part of the new hospital, or is it?
Well, no, it's not going to be part of the hospital. This is something I got interested in. And I started initially with my nurses, and then I saw that I was in deep water. And so I got Aileen Womack, who actually grew up out here, who has a huge experience at San Francisco General with addiction and psychiatric emergencies. And so she is the bad cop and I'm the good cop. She is very knowledgeable and very helpful to me, and we work as a pair. We're an unusual couple. How's that?
I'd like to see that in action sometime.
No, she is. She's excellent, very knowledgeable. She really delves into things. But what I'm looking for right now is to expand what we're doing. Right. First, I want to do this right, and right now I consider we're doing it pretty good. I want to get the counseling, and then we're doing it right. I'm licensed to have 100 people on Suboxone. I have 50 right now. I would like to expand, but I want to expand being able to provide those services.
So the person comes in, they have an issue, you give them a lower dose of Suboxone?
No, we sit down, we interview them,
Yeah.
we try and find out, what's their family situation.
Okay.
Is their girlfriend or boyfriend using, which means it's going to be harder for them. Why do they want to stop using? Are they serious about stopping using? And then we start them off on Suboxone, make sure we get the right dose. Then we see them weekly, every other week, or once a month, depending on how they're doing. And we test their urine every time.
Oh, okay. And are you seeing people that have been taking heroin for years?
Yes.
Right? And
yes.
So why would they want to stop if they've been taking it for so long?
Using heroin, people get sick and tired of being sick and tired. If you wake up every morning wondering how you're going to get the heroin, that's tiring. if you're wondering whether you're going to overdose, you get big infected lesions on your arm. If you're worrying about those things, that's not helpful. I mean, it's always criminal behavior. You're dealing with drug dealers. I mean, what can I say?
And is it recently this rash of deaths, overdoses that we've seen here on the island? Is that because the potency of the heroin is different from the way it's?
Well, I mean,
or are they just newbies into the?
No.
Have they gone from the opioid pill popping to the cheaper heroin?
No. What usually happens is you will get heroin. You don't know how many times it's been diluted, stepped on, so you never quite know what you're getting. And then there's the addition of fentanyl, which is several hundred times more potent. So all of a sudden you overdose, or you've gone off to rehab and detox, and you come back and you're clean, and you go back to the old dosage, and all of a sudden it's too much.
I see.
I mean, Narcan, people say we shouldn't have Narcan, but you know what? If it's your kid or my kid and they overdose, we want to see them alive. We don't want to see them dead.
That really works, the Narcan?
Yep. Like that.
Unreal.
No, it's amazing. It's
Yeah,
amazing.
it's amazing.
You know, and people raise questions about it, but I would rather have a kid alive that I can work with than the kid dead and I can be, holier than thou.
Wow. Well, anything else that I didn't cover that you want people to know about?
I think there's a real problem, and hopefully we're able to move ahead and do what
Well, you
envision.
tackled Lyme disease pretty well, right?
Well, Lyme disease
Are you
is
happy with the way that kind of...
Well,
I mean, it's still there, don't get me wrong. But do you see as many cases now?
We didn't see many cases last year because it was a hot, dry spring and summer. With this type of spring, we may be seeing more cases this year. We had a hard time finding ticks last year.
I mean...
This year, with a nice, moist, shaded summer, we're going to, or spring and summer.
Well, what about we have less deer, right?
No, we don't.
We don't.
Yeah. If you look at the deer herd, this is a good place to be a deer.
Okay.
If you look both ways when you cross the street, you don't get picked off by a Range Rover because that's the only predator.
Yeah.
And in shotgun season, you just see where they got posted signs up, go in there.
Yep.
You're going to live a good long time.
Yeah.
The food is excellent out here. There's plenty of feed for them.
Right.
So, we may kill 500 or 600 deer, but the deer stay busy.
Well, you'll be busy, that's for sure, it sounds like to me, Doc.
Well, no, there's a lot of interesting stuff in the tick research coming out now about some of the people that seem to have long-term Lyme disease. They don't really have persistent organisms, but I'm going to a meeting in a couple of weeks.
Well, I've had it 3 times.
Yeah.
But I don't feel the symptoms, or maybe I do, and I don't recognize them, but I don't have a problem at all with it.
No, because you got risky behavior, Gina. You got risky behavior.
What it is.
Yeah, it is. People that get Lyme disease have risky behavior. You're out someplace you shouldn't be, or you're not.
That's true.
Everybody wants a magic bullet. The magic bullet is check yourself for ticks. Find a girlfriend, a boyfriend, a good friend, a parent, and check yourself for ticks because they're very often in places where the sun doesn't shine.
Yeah, that's true. Very true. Well, Doc, it's great always. Thank you for what you do for the island, too. You're
a nice
great
ride
doctor.
around, even in the rain.
You got it, It was great.
Thanks an awful lot.
You bet.
What's there?
You betcha. Thank you.